It's time for another warm-up review. Let's get going. Which portion of the brain is supplied by the anterior cerebral artery? So this is the medial surface of the cortex, down deep in the longitudinal fissure. This is where the motor and sensory cortex for the legs and feet are found. Your middle cerebral artery supplies the lateral surface of the cortex. This includes Broca's area, Wernicke's area, and also the motor and sensory cortex for the face, arms, and upper body. Next, what are the symptoms of normal pressure hydrocephalus? Well, normal pressure hydrocephalus causes a reversible form of dementia where you have expansion of the ventricles. Now, most of the time dementia is irreversible, but this is the one where you can actually treat and make better. Now, the mnemonic for the symptoms is wacky, wet, and wobbly. So a patient would have dementia, urinary incontinence, and ataxia. Next, a 76-year-old man who recently suffered a stroke is brought to the clinic by his wife. She says that he now shaves only on the right side of his face, and he eats off only the right half of a plate. When asked to draw a clock, he draws just the right half of the clock face. A lesion in which area of the brain is most likely responsible for these findings? So this is hemispatial neglect, where the patient is basically unaware of one side of his body or one side of his world. So this is usually due to a cortical lesion in the non-dominant parietal lobe, which in most people is the right parietal lobe. All right, that's it for the warm-up. Let's get to that lecture.
In this video, we're going to be talking about pharmacodynamics, which is the relationship between the drug concentration and the effect the drug produces at that concentration. Let's start with potency and efficacy. We're going to look at some of the graphs that are somewhat similar to the McAllis-Mitten graphs, but instead of talking about the action of each enzyme on the substrate, we're now talking about the action of the drug to produce some therapeutic effect. Efficacy is the maximal response or effect that a drug can produce. We have dose plotted on the x-axis, but we've plotted it on a logarithmic scale rather than a linear scale, and that gives the curve an S shape. Then, on the y-axis, we have percentage maximal response, that maximal effect that the drug can produce. Think about a blood pressure drug. You give a little dose and you might lower the blood pressure a little bit, like 2 points. But you give a big dose and you might lower the blood pressure a lot, maybe like 20 points. And at some point, there's a limit to how much you can possibly lower the blood pressure. Even if you give more and more and more of a drug, there's a limit to how much the blood pressure will drop. And that limit is the maximal effect. And the maximal effect is basically the efficacy. Then, drug B is a second blood pressure drug, with a curve that looks like this. Maybe drug A is able to lower the blood pressure a maximum of 20 points, but drug B can only lower the blood pressure by 14 points at most. So we would say that drug A has a greater efficacy than drug B. So efficacy is only talking about that maximal response or maximal effect, and it really says nothing about the dose given. Then potency is the amount of drug needed to achieve a given effect. So efficacy has nothing to do with the dose given, but potency is all about the dose that you're giving. I'm not going to go into detail about how exactly we calculate potency, but think back to our example of blood pressure drugs. It looks like we get the maximal effect at about 1 on this scale. Let's say that's 1 milligram, just as an example. Now, drug C has the same maximal effect. So what could we say about the efficacy? Both of these drugs are capable of achieving the same maximal effect. They both lower blood pressure by 20 points or whatever. So the efficacy of these two drugs is identical. They're both equally efficacious. But for drug C, you had to give a much larger dose to achieve that same maximal effect. It looks like you had to give something like 100 milligrams to lower the blood pressure by 20 points. So, drug A is much more potent than drug C. Drug A has a higher potency. How does adding an antagonist affect potency and efficacy? This is another 4 or 5 star topic, so be sure to know how you interpret these graphs. Here in red, we see a receptor agonist, and then you add a competitive antagonist to the system. This is somewhat similar to competitive and non-competitive enzyme inhibitors. We're not inhibiting the enzyme, we're antagonizing a receptor. But the basic concept is the same. If the agonist is acetylcholine stimulating a cholinergic receptor, then an example of a competitive antagonist would be atropine. So what happens when you add atropine to the system? How does that affect the dose-response curve of acetylcholine, the agonist? A competitive antagonist shifts the curve to the right. It takes a larger amount of the agonist to achieve the same response. So, does that change efficacy or potency? It changes potency. You still reach the same maximum effect, it just takes more agonist to do so. So in this graph, the red curve is the agonist by itself, and the green curve is where you've added a non-competitive antagonist. With a non-competitive antagonist, the maximum effect is lower, and you can't overcome the antagonist by simply adding more agonist. So in this situation, efficacy is decreased. In this graph, we're not looking at an antagonist, but rather something called a partial agonist. A partial agonist is a substrate that stimulates or agonizes the receptor, but not as strongly as a full agonist. So because it has a weaker agonist effect, the maximum response is lower, which means the partial agonist has a lower efficacy than a full agonist. But potency is independent. A partial agonist could be more or less potent than a full agonist. It can shift the curve to the right or to the left, independent of what it does to the efficacy. To demonstrate that, look at this graph. The green curve is the full agonist, and the orange and pink curves are two different partial agonists. With either of these partial agonists, the maximum effect is lower, so efficacy is lower. But with partial agonist A, the curve is shifted to the left, which means increased potency. At a dose of 1 milligram, the partial agonist gives you the response of 25 or 30% of the maximum, while the full agonist response is only about 5% of the maximum. For any given dose, the partial agonist gives you a bigger response, up to about 15 milligrams, and then the curve crosses because the partial agonist has a lower efficacy. With partial agonist B, the curve is shifted to the right, and potency is lower. For any given dose, the full agonist will give you a bigger effect. So with partial agonist, the efficacy is always lower, but the potency could be higher or lower. Now let's talk about drug safety and therapeutic index. There are two components to therapeutic index. You've got an LD50 and an ED50. LD50 is the dose of a drug that is lethal to 50% of people. LD is lethal dose. So it's the dose that is lethal to 50% of the population. ED50 is the dose that is effective for 50% of the population. So if you divide LD50 by ED50, that gives you therapeutic index. You can have a high therapeutic index or a low therapeutic index. Now, which is better? Safer drugs have a higher therapeutic index. So a high therapeutic index means that the drug is safer. Let's think about that mathematically. Look at the numerator. If LD50 is higher, that means it takes a higher dose of the medication to kill the patient, and that makes it safer, right? And then consider the denominator. If ED50 is small, that means a very, very small dose of the drug is going to be effective, and that's also going to increase your therapeutic index. So a high therapeutic index is good. You can have a high therapeutic index either when the lethal dose is very, very high or if the effective dose is very, very low. So what are some examples of drugs with a low therapeutic index, where the toxic dose is only a tiny bit higher than the effective dose? A student sent us a nice little mnemonic for these, which is some drugs with low therapeutic index, which stands for seizure drugs, digoxin, warfarin, lithium, and theophylline. These are all drugs that we have to monitor on a regular basis. Low therapeutic index means the effective dose is pretty close to the toxic dose. You should also be familiar with the therapeutic window, which just means the range of doses that drugs are both safe and effective. If a drug has a wide therapeutic window, that means there's a big gap between the effective dose and the toxic dose. A narrow therapeutic window means that the gap is pretty small and it's fairly easy to go from a nice safe therapeutic dose to a toxic dose. Now we're ready for the end of session quiz. So pause the video, answer those questions, and we'll go over them together. First question. An investigator has developed 2 new preparations for insulin. Both preparations can lower the blood glucose by a maximum of 100 milligrams per deciliter. It takes 16 units of insulin preparation A to lower the blood glucose by 100 milligrams per deciliter, and it takes 12 units of preparation B to lower the blood glucose by the same amount. Which insulin preparation has a higher efficacy, and which has a higher potency? Efficacy is the reflection of maximal effect a drug can produce. Both of these drugs lower the blood glucose by the same amount. That means that both drugs have an equal efficacy. But for potency, you have to look at the amount of drug required to produce the same effect. And since it takes less of insulin B to achieve the same maximal effect, we say insulin preparation B has a higher potency. Next, your patient is taking experimental drug Z to lower his LDL cholesterol. When he is given the antagonist drug X, the potency of drug Z is decreased, but the efficacy is unchanged. Doubling the dose of drug Z is shown to overcome the inhibition by drug X. Is drug X a competitive or non-competitive antagonist of drug Z? If you can overcome the antagonist by adding more of the agonist, drug Z, then drug X must be a competitive antagonist. Remember, competitive antagonists will reduce potency, but they will not change the efficacy. Last one. Drug A has a therapeutic index of 10 to 1, while drug B has a therapeutic index of 2 to 1. Which drug would be considered safer? There are 2 ways to approach this. You can remember that therapeutic index is LD50 over ED50. So if drug A has a lethal dose of 10, say 10 grams, but drug B has a lethal dose of just 2 grams, and the effective dose is the same for both, in this case 1, then drug A is much safer. Or you can just remember that a high therapeutic index means the drug is safer. So 10 to 1 is a lot higher than 2 to 1. So again, drug A is safer. That's it for now. We'll see you next time.